Starting recording now. Hello again. This is ready again. I'm just starting again. This is our sim session in our teaching session. So we're going to do it for 3 hours. So we're going to do 3 sessions with a half-an-hour break. So the main thing is, but please concentrate what we're doing here, and you can write a note of it, what we're doing, and then at the end we can give a feedback. And I want you all to participate in the feedback as well. So for that, you need to follow what exact things are happening in a sequential fashion. Is there anyone who's going to volunteer to write down the timeline? Any volunteer from the virtual side?
Oh, Rangini can do that. Rangini, yeah.
Rangini, but just kind of write it down as you do the scribe. When you're doing cardiac arrest scenario, 8 o'clock patient arrived, 8:05,
okay.
Airway is clear. B, kind of timelines, what we're doing. If you're giving any medications, 8:15, we give IV fluid, 8, like that. Like if you do the timeline, at the end of that, we will be able to go through what we've done as a main kind of a scenario in a summary, and then we can go through the feedback. And the main thing in simulation is the feedback and how can we improve on the next time.
Okay.
So yeah, I think, are you happy to do that? And then we'll see how it goes in the next scenario.
Okay.
So there you go, guys. I think we have our candidates here. We're going to pick one candidate and we do the first scenario. Yeah. So there you go. So I think we the first
Is it on the bed? Is it that one on the bed?
Yeah. So I think if I want to give this scenario here.
So am I doing it then?
Are you happy to do that? Yeah.
Well, happy.
Yes. So I think if you all come here, so that all of them will be able to see us what we're doing here. I'll give you the scenario and then we will go through that. Yeah. So guys, we're going to have a 77-year-old man who started becoming unwell while going from the hospital, and he started coughing blood. He's recently diagnosed as having CA larynx. And 3 months ago, and he came to have radiotherapy today. And while going back, everything was fine. While going back home, he started coughing, hemoptysis. So his wife called ambulance, and ambulance is bringing them here. ETA 5 minutes, hemodynamically stable, GCS 15.
Right.
So if you're happy with it, can you repeat the story back? His name is John Smith.
You got John Smith, who's a 77-year-old gentleman who's got recently diagnosed with laryngeal cancer. He was having radiotherapy today, and then he went home and started feeling unwell all of a sudden and started coughing up blood. His wife called for an ambulance. His ETA is 5 minutes, and his observations apparently are stable.
Stable.
Well, we don't know if they're normal and stable, but they're stable.
They said it's stable, and the guy who took the call
Didn't write them down.
didn't write exact numbers as you normally have.
Yeah.
So he says it's stable, and he's coming to research because they're a bit worried about him because he's coughing blood. So you got 5 minutes to kind of prepare and do what you want to do, and then the patient's going to come in 5 minutes to research.
So I tell the research nurse, whomever that is.
So you have
I got a research nurse?
one research nurse today, and you
Okay.
have a foundation doctor.
Foundation doctor.
Who can do things, if you show
Some
him.
things, right. So Dr. Boone, if you wouldn't mind. Hi, you're the nurse.
No, sorry, F1.
You're the F1. You're the nurse.
We got
So
confused.
guys, we got a 77-year-old gentleman who's recently been diagnosed with laryngeal cancer, was having radiotherapy today, and then he went home. At home, he started feeling unwell. He started coughing up blood, and his wife called for an ambulance. They'll be here in about 5 minutes or less now, and apparently the observations are stable. That's all we know about him. So Dr. Boone.
Yeah.
Do you want to set up for IV access?
Okay.
So get all the stuff ready in the meantime. We're gonna need large bore access in the ACF, if you don't mind.
Yep.
At least one. And when you do access, can you do a gas?
Mhm.
Can you do plotting? Can you do FBCs, U's and E's, and then FTs, and then we'll see if they have a high temperature. We'll do a blood culture, but we'll see about that. Okay. Now, when the patient arrives, do you mind just attaching monitoring on the patient, please? And we'll need to set up for ECG as well, just in case.
All right.
Now, I don't know what you guys think, but my first impression is that we might be dealing with a PE, but we don't know yet.
I
Okay.
suppose the hemoptysis could either be coming from the
Or it
cancer
could be from the cancer, yeah.
or could be PE.
Yeah,
And there's question of whether there might be a
Airway
potential
problem.
airway problem.
yeah, that's true.
We don't know if the patient's a tracheostomy patient.
We don't know that.
We don't know.
That
So
is not
these are the
information.
few unknown variables
Yes.
to prepare for. So shall we make sure we have the airway trolley
Do we have it?
available?
Is that the average one?
This is the resuscitation trolley for you.
All right, let's see what we got here. Let's get acquainted.
I hope you're all seeing what's happening there, kind of checking the airway kit in a resus trolley.
Yes, we are seeing.
Fluids.
But where's my cannula?
Where's your cannula? Well,
The cannula is missing. Do you just pretend?
You spotted the cannula is missing, but I
Sorry, it's in it now.
that's good to know. There you go. As you're talking like this, then the patient arrives. King Kong, guys, I'm the ambulance person. There you go. So hello.
Hi.
This is with John Smith. He's been coughing at the moment. He's bringing a bit of a, blood as well. But his observation's all stable. He's a bit anxious though.
What kind of observation? What number have you got?
His heart rate is about 100 per minute,
Yeah,
and his blood pressure is 140/78,
yeah.
and GC is 15.
Respiration.
Respiration is about 32. Respiration rate 32. He's a bit panicky though because he's a bit worried. His lungs are clear, so his oxygen stats at 98%.
That's 98%.
Yeah,
Is that on air? On air.
on air, yes,
On
yeah.
air. Okay. Okay. Right. So if you wouldn't mind attaching some monitoring, that would be very grateful.
So Marius,
So there you go. Is it okay if I leave?
Thank you very much.
Thank you.
That's it. That's fine.
So Marius, I have now gained access. I've
You
taken some
gain
blocks.
access.
Two large for green.
Shall we talk to John? Hey, John. How's it going?
You're all right. I'm all right. I just coughing a bit, but this blood is making me more worried a bit.
Right. Now, when I listen to his voice, now, is there any sort of stride or is there any
No stridor.
change in his voice?
No.
No.
No change in the voice.
And this hemoptysis, is it so visible that it's so
Each time he coughs,
Yeah.
a lot of blood. So, I mean,
a lot of blood?
A lot of blood. Yeah, I think it's about a cup full of it each time if he coughs.
Really?
Yeah.
That's
yeah.
a lot.
How much?
A cupful.
A cupful every
A
time.
cupful every time. he coughs.
All right.
Right.
Let's see
We're
what.
gonna need a group and screen as well. Group and screen?
Yeah, I've done that already as part of the five tips.
All right. So, right, so
Do you
maybe
want
choking
on
on it?
that? You want me to ring for on that or not yet?
No, not yet. No. So, do you
Not
mind doing
choking
some
on it, no.
observations while we?
Yeah, I'm
we
just
get-
arrived the patient to the monitor.
Right. So,
You never really put,
is this quantity of blood obstructing his airway in any way?
No.
He's able to sort of maintain his own.
He's able to talk now, all right.
Okay.
But he's a bit coughing.
Okay. So then I'm gonna listen to his chest.
Yeah.
So he's breathing quite fast, isn't it? 32,
Yeah, he's a bit anxious. yes.
Dr. Reddy, there's a lot of feedback I can hear.
26 now.
26 now. So
Yeah.
I listen to his chest and what do
Air
I hear?
entry equal. Air entry.
Yeah.
Yeah.
And then if I percuss,
Resonant.
so no hyper resonance.
No
or anything.
hyperresonance or anything like that. No.
Okay. And if I listen to his heart,
Yeah, heart sounds okay. No
Yeah.
murmurs. If you're looking for.
how fast is he going?
He's going about what's this? 110 per minute.
110, so it's
Yeah.
gone up a little bit. And
Yeah.
what blood pressure do I have with that?
Yes, blood is 112 or 70.
It's gone down a bit, hasn't it?
112, yeah, I think
Yeah.
Dave, but the ambulance said 120, wasn't it?
Yeah, yeah.
Down, yeah,
112.
112
And
or
the
70.
capillary refill time?
Capital, if you do it, it's 1, 2, 3.
1, 2, 3. All right, that's a bit. And the pulses, peripheral pulses, are they equal?
Yeah, equal, and you can feel it.
Yeah.
Yeah.
Right. And you said D1. So I've A, I've done B, I've done C. D1 is he still alert and
He's
talking
talking
to
to
me?
you, yeah.
He's still orientated and
Yeah,
things?
yeah,
Yeah.
yeah. He's
And
talked to you
a
all
BM, have you done a BM with a gas?
Yeah,
You have a sugar level on
I've done
that?
it, but I don't, I'm
I've
waiting for it to
done
come
the
back.
drugs already, are they? Oh,
Yeah, I've done the
they're
gases.
very quick, yeah, I think, but James come back at 5.8.
5.8, okay. So that's about D and E. Examination wise, tummy.
Tummy is soft,
Nice.
actually, not
Yeah,
tender,
yeah.
it's not coming any pain at all.
Can I have a look at his legs? Does he have any evidence of DVT?
No, it's
No evidence
soft,
of
soft,
DVT, yeah, it's all
it's
soft.
not tender, not tender.
Right, okay. So,
As you're doing that,
yeah,
his monitor is beeping and the heart rate is about 125.
125.
Yeah.
So shall we give him a fluid bolus?
Yeah,
We'll
okay,
try
let me look at it.
50 ml of normal saline. What's the blood pressure with that?
If you check his blood pressure, it's going off now, it's for 98 or 56.
98 or 56.
Yeah.
All right. I mean, so give him the fluid bolus. We can fill the bed.
Just cough again. He's just coughing, big
Coughing
amount
a
of
lot.
blood came out. Yeah.
While we're here, do you mind bleeping the anesthetist, please? Because
Okay.
I'm worried that this guy's got hemoptysis that's so bad that it might eventually obstruct his airway. So can you bleep the anesthetist, fax the anesthetist to resus?
All right then.
If you
Right,
believe him now.
Tell me to stop, Marius.
Leave.
yeah,
They say they're on their way.
they're on their way.
Yeah.
Okay, so
Okay.
we've done that.
Yeah.
Has that made any difference with his heart rate and his blood pressure?
Heart rate still 120.
Yeah.
And blood pressure, I think the last one, as you done, is 98 systolic still.
Right.
Still
Do you
hypertensive.
want, so is he coughing up so much blood that he's
Yeah, it's not blood.
exsanguinating?
Yeah, you just can't, because I can't do that because
Right.
it's all about
We're
his.
gonna ring blood bank and get major transfusion back ready.
Okay, I'll go,
So,
I'll
ask
activate
for
the
that.
major transfusion
Yes, please.
protocol.
Yes, activated.
Major transfusion protocols activated. Yeah.
Right. So I'm talking to John. What is he like now? So what's his,
He closed his eyes and is not
Yeah.
as responsive as he was before.
yeah?
If you kind of talk to him,
John,
he opens his eyes with your speech.
yeah?
Um,
And what about his airway? So is he?
he's, there's no kind of noisy there, but it's all full of blood. He's kind of
Right.
struggling to keep it down.
Shall we
Need some
suction him?
Yeah.
Let's see if we can suction him. He's dropped his GCS now.
He's
Right.
a bit confused actually, and he's
Yeah.
just kind of talking a bit.
Right, so I'm trying to suction him and.
You suction that, and
Yeah.
that helps to clear the oral cavity,
Right,
but still, if you cock again, it's going to bring some blood again.
right, okay.
So
So-
it is helping a bit.
Yeah,
But,
is he
but
gurgling or anything? Is he making any noises or?
the noisy, the gurgling is there, but
He's got
it's not,
gurgling.
there's no stride or anything like that. at the moment.
Right, and do we're gonna carry on suctioning? Does
That is
that help with
helping
the
him.
noises?
That's helping a bit, yeah.
All
That
right,
helps him.
right. Does he, so do I sort of need to do sort of airway maneuvers to keep his airway open or not? Or is he maintaining
if you-
partially?
Do that,
Yeah.
it helps the noise a bit.
Helps the noise?
Yeah,
Right, okay.
definitely.
So is he, so let's try a Goodell.
Goodell?
Is he so GCS so low that he's gonna tolerate a Goodell?
Coughing and gagging is a bit, so
Is he gonna gag? Is he gonna, let's try to,
Yeah, if you move the bed, if you guys want to, move the bed forward so that you can go to the airway
Right.
side.
they're-
Just
so
leave
is
it.
that an incident
That's-
coming or
that's
not?
fine, yeah.
Or what-
And
what is this?
he's on his way.
Right,
So
so
try and-
is he tolerating a Goodell? No.
You Just gag her.
okay.
I don't want it.
So why don't we, I mean, if the GCS is high enough and is struggling with the amount of blood that's coming out, why don't we sort of turn him into his side? Instead of, maybe choking on his own blood, we could try and turn him on his side a little bit.
So if you-
Does that help?
Should we flatten the bed? Yes. We'll flatten the bed back on.
Got him. It's-
Can he tolerate that?
He's not tolerating that,
No?
he's so, he's not like, no, I don't want it.
So he was still wants on his back.
Yeah, he wants to stay back, but
Okay, so he's
as you guys are doing that,
Yeah.
anesthetic arrived, there you go, he just came now.
right.
His anesthetic, Reg actually,
Yeah.
just came in, kind of trying to want to know what's happening here.
So hi, I'm Marius, I'm one of the doctors in the emergency department. I've got this gentleman, he's 77. He's had radiotherapy today for laryngeal cancer. And when he got home, he started coughing up blood. And his wife called for an ambulance and they brought him into the hospital. Now, my worry is that he's coughing up so much blood, he's starting to choke on it. I think we might have an airway issue, especially since his GCS is coming down. I think he's coughing up so much blood that he's now dropped his blood pressure and is becoming very tachycardic. So we've organized a major transfusion pack for that. We've given him a fluid bolus, bloods have been sent. But I think this
While
gentleman
you're
needs,
kind of talking.
yeah,
But the monitor is beeping, that his heart rate is down to 60.
60,
Yeah.
right? Like, can we feel any pulses?
You can feel the pulse, yes.
We can feel a pulse. Why don't we put him legs up? And then, is that blood coming?
What's coming?
Blood is on the way.
So it's not
The
here?
data transfer protocol is there. I think they
Right.
are bringing it. It's on the way.
And with
In
that-
30 seconds, yeah.
That heart rate is 60. What does the monitor show? Is it sinus 60 or is
It's
it
minus 60, yes.
sinus 60? Right, and what blood pressure have I got now?
It's like 78 or 50.
Is it? Shall we
Yeah.
give him another fluid bolus, please?
Yeah, okay.
Yeah.
And when you look at it, his oxygen levels are dropping to 80% now.
Right, let's put some oxygen on.
Yeah,
For you, doctor.
Right, put some oxygen on. Now, we're gonna need to, well, he's gonna need to be intubated.
Yeah.
Right.
So you put an oxygen on, but still the SATs are not going up to, it's maximum 80% now.
Is it? Now,
And if you see his respiratory rate is kind of 8 per minute now, if you count.
is it?
Yeah.
All right. 8 per minute. So,
Yeah.
my friend, the anesthetist, while we get our stuff ready, do you mind just trying to take control of the airway? All right. And then we're going to start bagging him, isn't it? So, 100% oxygen.
Yeah,
And
he
start
started
bagging
bagging
him.
it.
Yeah.
So that's
Okay. So,
trying it, but anesthetist is like struggling whether he's able to bag properly or not. He can't do any chest raise actually.
really? Right. So what, let's suction his airway. I think it might be obstructing. Let's suction his airway. Does that bring anything up?
Bit of blood coming out, but
Yeah.
there's no improvement in his breathing pattern.
Is there not?
And now he stopped breathing.
Has it?
There's
So,
no respiratory rate at
but-
all.
Right, so it's not, so, are we managing to bag it at any point now?
He's struggling,
Struggling.
he wants to call his consultant.
Right, so airway agents, so we're doing airway agents, so Goodell,
Goodell.
right, let's try.
Sorry.
Yeah, right, does that, so jaw thrust, Goodell, does that,
That's kind of helped with the noise a bit, but
Yeah.
there's no breathing for himself actually. And if he's really trying hard to bag,
yeah?
there's no much of chest raise actually.
So we're looking at, airway obstruction now,
He's got
aren't
a
we?
pulse.
Yep.
He's got
Yeah,
a pulse.
so
too.
still got a pulse,
Still got a
okay,
pulse, but
right.
you're kind of like was struggling to ventilate.
Right, guys, so try an eye gel and basically we need to get front of neck access, don't we? This guy is obstructing from his cancer.
What's it happening with the eye gel?
Where's the front of neck access? Can you give me the front of the, we need to get ready for that, don't we? Let's try to get some landmarks on
So
here.
we don't have the difficulty of we kit here, do we?
So what do you want to look for different? I think that is like imagine
A
that's
surgical
there
airway.
in resource. There you go. So I think if you wanted to, what do you guys want now? I think if you could-
So,
Yeah.
are we doing any, are we
So
making
he's
any?
struggling. He called his consultant. Have you
Yes.
called his consultant already?
Hmm?
Ask an anesthetic consultant
Oh.
and already paid.
So actually, so 4 twos and just put out an anesthetic emergency in recess. And
Okay.
that's gonna get us more help.
Well done.
Okay. So we're not ventilating, we're not,
He's struggling, you know,
making
he's not
it-
able to.
right,
Because
but
even
this-
with IGEL gone in, but no, you know, no chest raise, and oxygen sats are now 60% on that. What you're doing.
right, can he intubate?
Yeah.
He can try. He's
Yeah.
anesthetic reg.
Since he's an anesthetic reg, can he intubate? Right, where's the, so, I'm gonna need the bougie, isn't it? There we go. So we're gonna have one go of that, and then next thing, we're gonna have to do front and neck access, okay?
Yeah.
So, does this guy still have a pulse?
He's still got a pulse.
Still got a pulse? Come on,
Lucky
so,
enough, isn't it?
okay,
So he's trying to intubate at the moment. isn't
yes,
it? And
And?
with the laryngoscope,
Can he see anything?
he cannot visualize it probably. There's a big clot, I think.
yeah, can he suction it?
He's trying to suction it, but
Yeah,
he's all blind and it's all blood there, and he
Right.
can't visualize it properly.
where's the, we have to do front and neck access now.
Okay.
That's it, we tried everything, we need to do front and neck access. Come
This
on.
is our difficult
So-
area. This is our
So-
surgical area.
Microthyroid membrane, okay?
Yeah, okay, like if you imagine.
So we've
What
got
do you need?
our surgical area.
So I need a scalpel.
The scalpel, imagine a pen, I think we can do.
Yeah.
Give a pen as a scalpel, guys, like
Yeah,
this.
so,
That's your for scalpel, if you think.
right, so I'm doing making an incision.
Yeah,
So first of all, I've established where the cricothyroid membrane is.
Yeah.
Making
you can feel it easily. He's a thin guy, so you can easily feel that.
Do a longitudinal incision.
Yeah.
And then sort of down. Then I need a,
And
so
so you
with
want
the
scalpel
scalpel, I'm gonna go through the membrane,
to the membrane, yeah,
yeah, and then put it transverse.
yeah.
Gonna need the bougie.
A bougie, there's a bougie there.
So
It's also
the
down.
bougie,
That's hanging out there, yeah, that one, yeah. There you go.
Bougie.
That's the bougie for you.
bougie.
So you're able to pass it through that hole.
Can't hear. Can't hear. Hello.
Dr. Reddy, there's a problem with the audio now.
I think whoever moved the laptop has muted.
And when I listen, so have we got a CO2 trace?
Yes, like you
We
will
do.
attach it now.
And does this
We
We
thing
can hear it
pop up?
now.
Yes,
And then when I listen to his chest, is there equal air entry?
air entry, equal entry.
Okay, what stats have we got?
Sats now is 92%, but it is improving.
Right, okay, so what about heart rate,
Heart rate now
Blood pressure.
100 per minute.
blood pressure?
Blood pressure is 106 or 78.
Okay, great. So we've done an intervention. So airway, were we happy with the airway? So does it feel patent? Are you able to bag him properly? Yeah, no resistance or anything. Okay, breathing wise. So I'm gonna listen to his chest again. We got
Air entry,
Air
air
entry,
entry, equal air
with
entry.
sats of 90,
94 now.
94, great. And then C wise, heart rate, what's it now?
Has a 110 per minute.
Right, blood pressure,
Blood pressure 110 or 76.
great. And then DCS is now 3, isn't it? DM was fine, wasn't it? Okay, so,
So the anesthetic consultant arrived because he fast bleed anesthetic consultant, and he came here now. So this is the guy. So what do you want to do now?
right, so I'm Marius, I'm one of the doctors in the emergency department. This is John Smith, he's 77. He's had radiotherapy today for laryngeal cancer. He got home, started coughing up blood, and his wife called for an ambulance. Now, we've been dealing with an obstructed airway. We've now been able to intubate him the oral, so we had to do a surgical airway basically on him because he was obstructing his upper airway. And now we've managed to stabilize him in terms of ventilation, oxygenation, and blood pressure. But this gentleman, well, basically he needs to go to intensive care now and have, you know,
We'll probably need to
definitive
get a
ailments.
lot of ENT to convert that into
Yeah.
proper trachea.
Yeah, yeah.
Or we'll do it, we'll see what we can do in intensive care.
Okay, guys, I'll stop you there. Woo. Woo. Well done, Maria. Okay, then I think we will sit around the table and then we can have a chat. How long it took for us to do this? Is it half an hour?
Yeah, exactly. How.
Are you all watching it okay? I think the kind of transmission is good, I'm sure.
Yes, sir.
We're just gonna sit around and then have a chat about it, all right? Okay, shall we just move this around so that we can have a bit of chairs around?
All right, so
We're all chairs around, isn't it? You're all able to see all of you guys. Just trying to. Okay, so all four are coming as well in this picture. Better, I think.
Yeah, we can see you.
I think it's okay. Maybe enlarge that something. Okay, guys. Marios, how do you feel about this scenario?
stressful.
How are you feeling?
Yeah, it's stressful. Airway management is stressful.
Stressful, isn't it? But
Stressful.
as a whole, how do you feel that you manage the situation well?
I think I could have done it quicker. I think I could have gone through the paces quicker.
Don't go
but
for the negative ones, but
overall,
what are
yeah.
the things you've done well, isn't it? Because like overall,
Overall,
we go through each point
yeah.
in detail, but overall, how do you feel? Like you know, he managed the situation well, isn't it?
Yeah, but we managed to
Managed.
establish an airway for that gentleman. That's the main.
That's the main thing, isn't
Main
it?
thing, yeah.
How you guys felt as he leading the team? Was he kind of good in the management? Yeah.
I think he was clear.
He's clear in his instructions and he's saying things what he wants. Guys, we are there. We have to do something now, isn't it? Yeah. I hope you're all following as well, isn't it? Yeah. So obviously, you know, we just go through the timeline to give a gist of it, what exactly happened. Rangani, can you just give a kind of summary? I mean, say, you know,
Yes.
what exactly happened at each stage? Yeah.
Yeah. So
Like you're on mute now, I think.
No. Can
Hello?
you hear me?
We can hear you, Rangan. Yeah.
Are we on
Yeah,
mute?
yeah.
No. I don't think
Yeah.
we're on mute.
We're on maximum.
We're on maximum.
Hello, can you hear me?
Yeah, Rangani, I can't hear you.
My phone is not mute.
Are you talking, Rangani?
Yes, I'm talking.
We
I'm
can
talking.
hear her.
I can hear it on my side. Yeah.
I can hear her too.
Make sure that, are you all guys able to listen what I'm saying? Yeah. Hello?
I think
Yes.
Reddy,
Yeah.
your sound system
Yes,
is
everybody's
probably
muted, is it?
defective.
No, they can listen to us, but we can't.
We can't hear them.
We
Reddy,
can't hear
can
you.
Can you hear me?
Is that
Hello?
because-
Yes, Rangani, we can hear you. I think it's problem with their sound.
See, because
Okay.
we logged off for a while.
Yeah.
We have
The
been
speakers
able
are
to-
100%.
Yeah.
Hello.
I hope you're all able to listen what we're saying, but we can't hear what you guys are saying. I'm trying to kind of give you access to the system's speakers, is it? System. Everybody's muted, isn't it?
No, we.
Yeah.
Here we go.
But now I can hear.
Yeah,
Rangani,
hello.
Yeah.
Can you hear me?
fine.
Yeah.
Yeah, good.
Yes. Okay, this we received this phone call, red phone call at 9 9
Yeah,
9 a.m. Telling that 77-year-old patient, male patient with CA larynx is coming with hemoptysis
yeah,
after radiotherapy, quite stable patient.
yeah,
So 9:14, patient arrived at resus.
yeah.
On arrival, patient had tachycardia. Blood pressure was stable, GCS was 15, respiratory rate 32, and saturations 98. So the Airway took the doctor took the leadership, and so he assessed the Airway breathing, circulation, disability, exposure in that order. So all were stable other than pulse rate of 110. So at 9:18, so 4 minutes after arrival, heart rate went up to 144. Blood pressure dropped to 98/56. And that moment, AED doctor decided to give a IV fluid bolus. That is 4 minutes after, 20 milliliters per kg given. And 9:19, 1 minute later, he called the anesthetist registrar because of the concern of Airway. Then this patient was continuously coughing out blood. Then 9:20, that is 6 minutes later, blood bank was informed. And 9:20, patient became unresponsive. Patient was not responding to speech. So there was a GCS drop that was detected. And then 9:21, patient started noisy breathing, gurgling. And then that moment, this airway concern came. This patient had a gag reflex. So there was a bit of difficulty in managing the airway. 9:22, that is about 4 minutes after informing, anesthetic registrar came. 9:23, patient started further deterioration. Heart rate dropped to 60, but pulse was there. Then it was sinus tachycardia, sinus bradycardia, 60 beats per minute. The fluid bolus was running. The saturation dropped to 80%. That was at 9:23. That was 19 minutes after arrival. Then 9:24, saturation was 80%. Then this moment, everybody was struggling with the airway. 9:25, there was no breathing. 9:26, anesthetic registrar called his consultant because of the concerns of airway obstruction. Now, it was difficult in ventilation and difficult in sort of maintaining the airway. So then all of you decided to access the neck, anterior neck, for surgical airway because of the concern of airway obstruction due to clot or cancer. So successfully done. Then 927, anesthetic consultant called. And then that time again, the saturation was 60%. Now, somehow in around 9:28, front of neck access done with cricothyroid puncture. Then luckily 9:30, it was a success. Saturation 92, heart rate 100, and blood pressure went up to 106/78.
So it's kind of hand over
So
to-
9:31, anesthetic consultant arrived.
So that was a wonderful kind of a timeline, Rangani. Thank you very much for that. But obviously, all you guys know, whoever missed in the beginning, know what exactly happened in the last half an hour. Yeah. We just wanted to kind of concentrate on the three main things. I don't want to go through everything, but A to E assessment, one of the main thing is that, and then anticipating and kind of using the resources appropriately. And then how do you do the surgical airway? That is the main focus of this kind of task today. Yeah. So I think if you're going through the kind of initially, when you know the story, what happened, you okay? You guys say something? Initially, when you given the 5-minute task, like you were preparing for the things, what's going to happen, isn't it? You know, ETA time was 5 minutes. At that moment, what were you thinking? So you guys were talking about, okay, maybe he's bleeding out, possibly hemoptysis. We're thinking of major hemorrhage protocol.
Yeah.
Wasn't it? Yeah.
Or a PE.
Or a PE, like you said, PE.
Yeah,
Isn't it?
PE.
Possibly because he's a cancer guy. He started coughing, possibly PE, possibly his hemoptysis going off, and then massive PE, maybe cardiac arrest. But you mentioned PEA, maybe PE going to PEA.
Yeah.
That is a possibility. That's the good thing of planning, isn't it? And then who said airway issues? Maybe there. I think it's Boone. Boone said airway might be a problem because he's not have laryngeal cancer.
Not only that, but the radiotherapy.
The radiotherapy causes to kind of bleed, isn't it?
Yeah, bleed and edema. So.
And then cause airway compromise. We have to look for difficult airway trolley.
Yep. Yeah.
But that is an important thing as well, isn't it? I think by that, it really helped you guys to look for and organize what things needed there, isn't it? Are the instruments available there? Is the difficult airway trolley there or not? That's wonderful of you guys planned really as a team. That's really good. And after that, when the handover happened, we wanted to make sure that he's hemodynamically stable. What are the numbers? The numbers are all right. His airway is fine. That was all right, wasn't it? And then ATE assessment. How did you do that? Did you guys put oxygen on him initially?
No.
Because it's not really required at that point, wasn't it? Like he was saturating well.
Yeah.
He's talking to you guys, like you're happy with airway. And he was quickly gone to B and he's examined the B bit and he was happy with it, isn't it?
Yeah, I mean, his respiratory was initially hard, but then he settled. So it was a little bit of an element of anxiousness, but then he settled fine. His chest examination was clear.
Yeah. And I didn't even realize that they have allocated Boone to do the venous access and all the bloods, he's kind of sick like that. And he's done a venous cannulation, bloods and VBG and all that is ready.
Yeah.
This is an important thing of allocation. That was also an important point initially. Before patient arrived, like you allocated Boone to do kind of access bloods and we might have to think of major protocol and assist you to kind of monitoring, isn't it? So it's kind of giving them the tasks and come back to me kind of thing. That's really good of you. So he already did the bloods for you.
Yeah.
And you got an access already, isn't it, by that time? And you started giving fluid, isn't it, at that point, wasn't it? That was good. And you discussed the issues and you allocated roles and all that. That's really, really good. And you asked for BMs, A, B, C, D, E approach, right? Like you didn't miss D bit.
Yeah.
And you asked the, GCS score and all that kind of thing. I was really impressed with it. And also, what is the BM?
Yeah.
In this scenario, it's easy to miss Y BM, but in a systematic order, if you make sure like you're not going to miss things, go through a list of it and tick boxes there. BM is okay, fine, go ahead again. And then at what point like you felt, oh my God, it is changing the direction here?
So it was the huge amounts of blood that was bringing up. It's really hard because normally airway assessment is a very sort of, you can hear it.
Yes.
It's
difficult to kind of, kind of
on a
show you
machine
that. But I was coughing a bit. I was trying myself to cough and bring up blood a bit, but obviously at that point, like you're thinking, oh my God, airway issue, isn't it?
Yeah.
And he said something, I need to have anesthetic help here.
Yes, because
we might lose the airway, call anesthetic now. It's kind of, important, kind of recognizing it.
Yeah.
Anticipated that we're going to lose the airway. You guys already anticipated even early, isn't it?
Yeah.
Even the patient arrived, possibly a difficult airway, and you recognized it and you contacted the anesthetic. That's the good thing, isn't it? He was still talking to you.
Guys, we can't hear you at all. I think there's some problem with the audio.
Sorry, are you able to hear us? Hello?
Yeah, I can hear you.
Yeah.
We can hear you. Yes, we can hear you.
Yeah, because say something if you are not able to hear properly, and I'll give you a chance to talk as well. Yeah, each of you. Yeah, okay. Are you all following us? Yeah, we're kind of discussing point by point and where he wanted to improve or things like that. Yeah. So
yes,
at the point like you are losing the airway, like you kind of thought of losing there, and you asked an anesthetist guy, and then he was hypotensive, wasn't it? At that point, he kind of dropping blood pressure. Then you asked for, major hemorrhage protocol. Where is it? It's not coming yet, so we're going to start some fluids and things like that, isn't it?
Yeah. So I did a second fluid bolus I think we did 2 fluid boluses. So I asked for a second fluid bolus because yes, we were engaging the major transfusion path, but that was going to take a bit of time. So in the meantime, let's give a fluid bolus because the blood pressure was dropping and it was becoming more tachycardic. But
how much fluid were you giving at that point? The 250 boluses, was it?
250
That's
and
good.
another 250.
That's
So
good. You
now,
don't want to give more.
yeah, exactly. Because if we're thinking, oh, he's bleeding out, you don't want to.
You don't want to give
full of fluid. Yeah, and dilute his clotting factors
Yeah,
even more. Yeah.
blood to blood, isn't it?
Yeah.
It's better to give blood as soon as. Is there anything else you want to consider giving then at that point?
I wanted to talk about
TXA.
TXA maybe. Because whether ONEG, if he's hypotensive, who's bleeding out in front of you, those are the options maybe. Like you can give some little like fluid. If there's no response to it, then you think of ONEG or major transfer protocol anyway is activated. It's going to come very quickly, I think. It's not taking a long time, isn't it? As you already ordered, is there any element to whether, like if you're thinking of his hypotensive initially, when the handover was given, if he was hypotensive, was there any point of alerting the blood bank when you're, planning your situation? Maybe giving a heads up. Hello, blood bank.
Yeah.
I'm having a patient who's hemoptysis, who's hypotensive, but in the handover, in the Ashai's call, he was hemodynamically stable.
Yeah, blood pressure
There's no
is fine,
point at
yeah.
the point. But if they are hypotensive,
You refuse to say the numbers.
yeah, because this is because it's important for us to kind of ask the numbers. If you're taking, Ashai's call, what is the stable means? Paramedics might feel he's stable.
It could be stable hypotensive.
The stable hypotensive. So
Stable just means not changing.
yeah.
Yeah, exactly.
So
Stable.
so ask for the numbers, because like if you're taking Ashai's call, what is the heart rate, what is the blood pressure, what is the pulse rate, and what's their GCS, things like that. So it was good, wasn't it? Yeah. And then what happened after that? Like you called anesthetists and he's arrived.
He's arrived.
Was it a good moment for you? Yeah, we have an anesthetist now.
It was a good moment. I give a brief handover, and then basically we needed to proceed to secure the airway. And then the patient had a sort of a respiratory arrest, didn't he? And then we realized that he wasn't baggable. The airway maneuvers weren't helping. Airway agents weren't helping. iGel wasn't helping. So, very sort of early on, I said, we're going to go through these, but we're going to need the airway, the surgical airway access. So that got it quick.
When you realize that, his oxygen sats are kind of dropping and his respirator is about 8. When I mentioned that, okay.
Yeah.
There's the kind of moment that, okay, so I think his respiratory arrest situation, he kind of stopped breathing at that point.
Yeah.
And then you kind of walk, okay. And he said, I need to have front of neck access.
Yeah.
That's a good thing to say because everybody understood. I don't know how you guys felt.
Yeah.
Because at that moment he said, guys, I think we're not able to ventilate him now. So we need to access his front of the neck.
My only thoughts was when the bag and mask was converted into iGel, I thought he was able to ventilate. It's only when he then tried to intubate.
No, he was not able to ventilate because I didn't say that, because
No,
I said
struggling.
So
he
the
was able
iGel
to
was
pass it in, but he's bagging it, but his chest is not raising, and there's no improvement in oxygenation. So it's like, he passed it in, because it's kind of putting the airway in, isn't it?
It's essentially at that point you trigger the DAS algorithm, isn't it?
DAS. What does that
Difficult
mean?
Airway Society.
With Difficult Airway Society, guys. I don't know how many people know about it. DAS. Difficult Airway Society guideline or something like that. If you can't intubate or ventilate,
Can't intubate.
Yeah.
what are you going to do then? You're going to, like he said that word. I need to
Neck
access the
access.
front of neck access.
Yeah.
For now.
From access.
Front of neck access. So have you ever kind of done that before? Have you done it before?
I've never done it. No, I've done it in simulations, but never
You've done it.
live.
Anybody?
But to be fair, so I had a patient this week on nights,
Okay.
not this week, last week. on nights who had a respiratory arrest because he vomited and aspirated. So we couldn't bag him, we couldn't intubate him initially. So the first attempt was negative, it wasn't in the right place, it was failed. And I did ask for front and neck access and I was ready to do it,
Okay.
but he got intubated while we got
Is anesthetist there? Is that
yes, the
right there?
anesthetist was there. Yeah.
He's the one who failed initially.
Failed in it, yeah, it was the anesthetist SHO.
And then he can fail, and then you're going for access.
And I was like, we need front of neck access now.
See?
And while it was happening, while they were trying to find it, and he tried again, and he managed to intubate, but it was like, it was food, big chunks of food that were stuck in his throat,
Yeah.
and we couldn't suction them.
So yeah, I think guys, there is a guideline how you do it. There is a wonderful video actually, what DAS has advised how to do it. It's very simple, they say, but like if you do it, I don't know how easy is it, but have you ever done it from the group, apart from anesthetists sometime? Anybody? Have anybody done any emergency surgical cricothyroidotomy, surgical airway?
No.
No.
Yeah, no, I have done, but not in here. I've done back home quite a few.
Quite a few. Aftab, yes, you have to learn from you.
In 80 to 100% burn patient.
Yes, yeah.
Oh, yeah.
But that's the difficult situation as well, isn't it? So obviously, there are kind of so many techniques are there, but what you followed was good, wasn't it? Can you explain what you did to the kind of whole team?
So in emergency situations, you just do a longitudinal midline incision. So you don't have to be very precise, just do a longitudinal midline incision, then go through the cricothyroid membrane, turn the scalpel, then insert the bougie, and so don't take the scalpel out, then insert the bougie, and then railroad the tube on the bougie, and then take the bougie out.
So the main things are here because according to DAS, for scalpel, bougie, and ET tube, that's it you require. You don't want to have anything else. So a scalpel, number 10 blade, yeah? And the bougie, how many guys have seen the bougies? Bougie. It's in our airway trolleys, actually. It's kind of a kinky thing, isn't it? So you have to pass it through.
It's a flexible wire, is it? Flexible
Flexible
plastic
wire.
wire.
It's kind of railroading it because it's like a wire in chest drains. It's like this, yeah? Pass it in, and then you'll railroad this with for size 6 ET tube, and that's it, yeah? So, I want to show you that video. I don't know whether you'll be able to bring it down there, like share a video kind of on YouTube if you want to see it. So it's like, I'll explain initially what we're going to do. I want all of you to see that quickly. It's only for 2.5 minutes actually. So if you see that, like, how to do it in the emergency situations. Yeah, we could say, DAS, surgical cric. Surgical, go to DAS, surgical cric. Surgical cric, surgical airway, something like that, yeah. There's that one, yeah, that one. That's kind of 2-minute video. You got to share it, isn't it? Guys, have a look at this video. It's very quick and see how he's doing it. I hope you see it and it'll be wonderful. Share it, is it? Share sound, optimize video clip, share. How do we know that they're able to see it?
Performing a folks, Ross here from Open Airway. I'm in the UCT Anesthesia Airway Skills Lab, and I'm going to go over in this short video the Difficult Airway Society's 2015 guidelines surgical airway technique. Now, I'm not going to go into the debate about needle versus surgical cricothyroidotomy. I'm also not going to go into the debate about scalpel finger bougie, scalpel bougie tube. I'm just going to demonstrate the DAS technique on this mannequin. So obviously, we're going to be in a can't intubate, can't oxygenate scenario. We're going to have tried our other options and recognize that we're unable to oxygenate this patient without going to front of neck access. The equipment that I need for this procedure is I'm going to need a scalpel. DAS recommend a size 10 blade, but use what you have immediately at hand. I'm going to need a bougie. you want a Coude tipped bougie, and preferably a hollow core bougie if you've got it, so that you can oxygenate as an intermediate step if necessary. And you want a size 6 standard endotracheal tube mediate lead hand. Right, so to perform the technique, we are going to do the laryngeal handshake, feel the larynx and make sure that we've got the cartilages in our fingers. Feel down in the midline with my finger and identify the thyroid and cricoid cartilages and the cricothyroid membrane. If I cannot feel the cartilages clearly at this stage because of a patient with a thick edematous or fat neck, I'm going to make a vertical incision in the midline and blunt dissect with my fingers until I can feel the cartilages. If I can immediately feel the cartilages, I'm going to make a vertical stab incision through the cricothyroid membrane. Remember that you want to do this vertically so that you have got the wide, broad cartilaginous part of the cricoid behind the tip of the blade. I'm then going to turn the blade sideways. Now at this stage, I like to work with my dominant hand. I'm going to swap hands, and using the Coude tip of the bougie, I'm going to pass it down the trachea, and it should move freely. I can now remove my scalpel and make it safe, confirm that my bougie is moving freely. If I've got a hollow core bougie, I can already oxygenate at this stage. Otherwise, I'm going to connect and railroad my size 6 tube with a slight screwing motion if I have to get it to go in, just until it's into the trachea. Out comes my bougie, and now I can connect and oxygenate the patient and inflate the cuff, etc. So, that is the Difficult Airway Society's 2015 guidelines on performing a surgical cricothyroidotomy.
So we can go back to.
It's all nice and good when you see it on the video, but you've never done it in real life.
Okay, yeah, we're back.
So guys, yeah,
What is the scalpel size? They said
10, size 10 blade, size 10. At that point, if you only get size 11 blade, that's fine, because it's a kind of scalpel, kind of stab, twist, pass the guide wire, and then the tube.
why that vertical thing? Why we can't do it horizontally? I mean, the cricothyroid membrane is a narrow area, isn't it? So why, if we do vertically, so can we cut the cricoid cartilage? I mean, I know it's a difficult thing.
Yeah, because the landmarks is very difficult to feel, but it's, at that point of the time, it is very critical to go into the airway, isn't it? So they found it's easy to do the kind of, vertical stab, horizontal stab, twist it, and then pass the, if you can feel the landmarks well. If you can't feel the landmarks well, do a longitudinal incision while fixing the larynx in the midline. And then once you see, blunt dissects it with your fingers, and then stab after that.
Okay.
So I think because it's easy to see on a mannequin, it's easy to he did it within 2.5 minutes, and now Marios Baltescu has done it in less than a minute. It's easy to do on the mannequin, but in real life, it is tough to. But at that moment.
I have heard that thyroidea, ima artery or something running across, and you can damage that artery or something like that. I mean,
we're kind of dealing an emergency situation there.
It's, I think the anatomy of the neck, there are strap muscle, is it? So on the either side, and the midline is bloodless field. So if you feel your own thyroid, so apex of thyroid, and then the next ring is a cricoid. Cricoid is a toughened set of cartilage because the tracheal rings are softer. Hence, they say down damage cricoid cartilage because that's the basis of the tracheal rings, like concertina effect. So you push your finger there, and then I think any blade really, because it's an emergency, is it? So whatever the blade you have, you go vertical as the video person is saying, and then you can rotate the blade itself, or sometimes they put the handle of the blade in and rotate through.
They're kind of different techniques, actually.
Absolutely. And it's an emergency really. So if you won't do it, that guy is going to die. So believe me, even if you cut the required cartilage, it doesn't matter at all. If the person survives, because it can later be fixed up and stitched up.
But if you know what to do, then you can assist and you ask for help, isn't it? Because as Maria said, guys, we can't intubate him, we can't ventilate him. That is the main word you guys need to feel. We cannot ventilate him. Whatever we do, we have to do all the approaches, you know, kind of airway kind of techniques, adjuncts, and you're doing bag mask ventilation, and you ask anesthetic help. Even anesthetists are unable to. If you're in that situation, kind of declare it. He declared it. We can't ventilate him now. We need to access the front of the neck. That is the important kind of thing. As a team, all you guys felt like that, isn't it? Yes, we have to go for it. In that situation, I think you all will feel it. Yes, we have to go for it. And then, like, if you know how to do it, you know, we only need 3 things, and it's doable. If anesthetists are not happy to do it, as a registrar, as a consultant, we'll be able to do it. But if you know, I don't want you all to do it on a patient, but you know, recognize that situation. That okay, I think it might happen here. It could be an airway issue. So ask for help early. Ask your you know, ITU guys or your senior guys in your floor. You know, like registrars or consultants are there, isn't it? As a team, we'll be able to. You know, a single person won't be able to do that. No. You need assistance, isn't it? Yeah. So it's kind of a teamwork and helping each other and raise the alarm early. Yeah. So guys, I think if you go back to the scenario, he, you know, while he's gone to go to the front of the neck, he asked to fast bleed anesthetic consultant, isn't it? 222, yeah. Anesthetic emergency, ask him to come down. Because after he's done it, he needs like some team to take him to somewhere, isn't it? So we need to ask help, ask them to come down. Yeah. That was good. And after that, you successfully done it, and you successfully handed over to the anesthetic team with an S-bar technique. How good was his handover? It was slick, wasn't it? You know, he followed the S-bar technique. I hope you all kind of felt it. You know, a simple kind of gist of what has happened. He's 77, who is known laryngeal carcinoma, you know, came in and we lost his airway, and we have to do surgical airway. And we successfully resuscitated him, and can you please take over? You know, I think it's kind of had to be very slick and easy to kind of hand over, isn't it? That was really, really good. And the way you used your resources and the way you know, ask for help early and the way you were kind of delegating your team was really, really good. Anything to learn from you in this situation? Any kind of learning points today with this scenario? Marius?
So I think with learning points, declare it, because people need to hear it. They might all think it, but somebody needs to declare it, because that's when things start moving. Otherwise, just people think, oh, we should do that, but nobody actually takes any action. So you need to declare it. And to be honest, there's no problem to have, you know, the surgical airway kit next to you, just in case. You know, if you're not going to be able to intubate, you need to know that it's there. And it's not something I've done real life, but I came very close to it the weekend that just gone. So you just have to declare it.
It can happen, yes.
And then bring help early. Be honest, because it's airway. You need an anesthetist there. And what else?
I think initially when we weren't sure whether the hemoptysis is secondary to bleeding or PE.
Yeah.
But when it became quite obvious that it's actually bleeding, maybe at that point TXA should be considered. I'm not familiar with how quickly it works, but there's plenty of evidence now that TXA works in emergency situations to help improve prognosis.
Yeah,
isn't it? There's now enough evidence for all sorts of different bleeding scenarios.
Because I think we're giving it, but obviously the only positive evidence base for help is in kind of trauma. But in others like upper GI bleeding or in hemorrhage in pregnancy, there's no kind of real benefit or risk.
So for this,
it's
it's
kind of
like,
yeah, because there's no harm in kind of giving it, but there's no proper evidence yet. But I think you can consider
but
it.
he had a bigger problem. He had an A problem.
Because A
Not a
problem,
C
isn't it?
problem.
Yeah, it's not.
Well, it's a C problem as well, but the A problem takes precedence over the C problem.
That's really good. Yeah, yeah. Is that it? Yeah.
Yeah.
Guys,
Probably the
what
usefulness
is
of the ABCD.
what is your learning point, Boom?
Uh,
Is anything else apart from
I
those?
like how he delegated and
Yeah.
planned the team. I think that worked. So it was very clear in my mind what I needed to do.
Yeah.
And I think that's certainly when the next time a similar type case come in and I actually have the resource. Quite often we don't have enough people.
Yeah.
If I have the resource, I will do exactly what he's done, which is
But-
delegate,
Yeah.
plan and say, this is what we think might be happening.
Anticipate it.
Anticipate the potential problems and complications, get ready the things. And then when the patient arrives, they just crack on with
the team approach, isn't it?
the various delegation, the task that's been delegated. I think that is nice, and it simplifies for the leader some of the other things he may have to do to then start making decision. While he's doing all that, the rest of the team members are cracking on with the other stuff. So by the time he finished thinking, in that 10-15 seconds, other things have happened.
Yeah, yeah.
And I think that works.
That's important because you do need to have the team at that point. Like if you think the situation is going to go wrong, you need to get the people in.
So drag
If
people in.
somebody is working in unplanned care or somebody is working somewhere else, if you need that team, if you think the situation needs extra 2 people, bring them in because we need to save the life there. It's not about how to reduce the queue. It's about saving life, isn't it? Like if you need help, ask early. Whether is it from the department, maybe one approach. The other approach is to call help from other specialties. If you think you're really doomed with A&E, you ask the specialties. Like you can ask the ENT guy in the situation, possibly I'm worried about he might lose his airway. We might have to think of surgical airway maybe. So ENT come down now. So then like you can use other specialties, yeah? And anticipating and planning is really going to help you, in the next kind of couple of hours, isn't it? Otherwise, like if you don't anticipate, oh my God, it's a human nature to kind of move back. Oh my, okay, we're losing the airway now. Everything becomes blank. I didn't plan it. Because how many times we see, oh, kind of like shocking moment. And then by the time you kind of come back, it takes a little few moments, isn't it? So if you plan it early, and as a team, like you're thinking of PE,
yeah,
and he kind of added the airway bit. Okay, maybe I need an airway problem. So as a team, we can have more kind of collective thoughts into it. Yeah, that's good. And what, Shishir, have you learned anything? What was your, apart from those, is there any extra one like you?
Yeah, I think as a team in this simulation, I knew what was going on and I knew what we were doing as a team. That was really important.
That's important, isn't it? Yeah.
Because even with Airway, like he was taking the ladders, maneuvers, adjunct, and then try a definitive airway, failing, going for surgical.
It was like a stepwise manner, isn't it?
Yeah.
So he kind of asked him, is there any kind of gargling noise I'm doing? He did the suction and didn't help and tried to do the
Reddy, can't hear you.
The problem that with the record,
Reddy, can't hear you.
cancel, is it? Failed to detect your microphone and speaker.
Oh no, we could hear you now.
So yeah, that was good because he was clear enough to kind of declare or saying things, guys, we're having an airway problem. As simple as that. Because maybe they may be, apart from the doctors, they may have nurses, healthcare assistants, medical students, that there's so many other allied professionals there as well, isn't it? So if you say simply, we're losing the airway now, we're going to go for surgical airway, then they know and ask for help, crash bleep or for 222s or 4.2s to anesthetic department or, something like that, ask for help and then everybody comes in. That's good, isn't it? Yeah. And anything from you? Have you learned anything?
Yes.
What is your kind of learning point there? Apart from those, well, obviously.
Yeah. it all basically has been said, but I want to emphasize on handing over as well, how crucial it is to keep it short and sweet. Because I was just come down and he filled me on with everything that I needed, and it wasn't the time still wasn't because the patient crashed while we were having a chat. Just
So it's kind
shows
of
us how
for the importance of S-bar technique, isn't it? Because how many other times we say S-bar, I-S-bar, because I added I now, will identify the doctor whom you're handing over to. But if you don't practice it, it won't come naturally, because you have to practice it. They have to practice it. Guy, I have 44-year-old, I think it is PE. Then the kind of buzz alarms goes up, because all specialties want that buzzword, isn't it? Is it PE? Or is it surgical? Oh, surgical airway? I've done it. Oh, I'll come down now because I haven't seen it before. Because everybody's enthusiastic, isn't it? Because you need to say that buzzword and then give the history after that. But they don't bother about the history. What exactly is the scenario? Why you're asking me to come to A&E? Because I'm busy eating in a canteen. I want to come down. Why? Why I have to kind of drop my baguette, what I'm eating, to come to resource, which is busy, which is a shit. This is the reason why you have to say, I've done this. Is surgical airway. He's now saying, oh, okay, I'll come down now. So it's like that, kind of say that word, and then assessment what you've done, and then they recommend why you're calling him. I want you to take to ITU. He needs to go to ITU, or he needs to have a definitive airway. Good. How about you?
Yes.
You came in a bit late, but obviously I have seen that video. Yeah.
So in airway management, we have to go step by step, starting from the basic maneuvers and adjuncts, and ultimately, if the only thing remains after, if the patient is unable to ventilate or intubate, then the thing remaining is surgical airway. So we need to consider that in that condition. That is what I learned.
Good, man. Good. You all happy with it? Yeah. So I think from the virtual team, is there anybody wanted to say anything what you learned today?
I think this is the moment, because I've
have I lost their
attended
thing
your sim
again?
session.
Oh my goodness.
Can
Each
you
time it's
hear
doing
me?
it, isn't it?
I think it's
Ready? Can you hear me?
because we are. I think what you need to do is change settings to log off after a certain period of inactivity. Same as system.
Same as.
I just click on the other one, then back on the system.
Ready? Can you hear me?
Yes,
Yeah,
yes.
we can hear
I
you
can
now.
hear you
Yeah.
now.
Now, okay. Now, this is the first sim session I've attended.
Only thing is,
I think it's a fresh air. Okay, what we call air in the fresh air. Okay, in our department, and we were struggling to arrive at this point for quite a few years now. I think we are getting there, but not quite yet. Okay, that's very important, because I must say that. Okay, now I think regarding scenario, in the beginning, the discussion was very good. So they discuss about the thought of different options. Okay, and now then the step-by-step approach, that was excellent. Okay, and action were taken, and and then they arrived at the right diagnosis, and the patient was saved. I think these are good things. Yeah. And Rangini kept a log in a very systematic way in time orders. I mean, in a way, Rangini was a bit more observant and vigilant than all of us, quite frankly. Okay. I think the thing should happen, like, for instance, once any scenario is finished, then we should ask the candidate how it, so what went good, what went well, and then we listen, give him 5-10 minutes, and we listen, as a critique, and the candidate should be able to say what good things happen, and then the next question has to be how it could have been improved, because we don't want to squeeze in the bad stuff. No, what bad thing happened? No, how it would have been improved, or something like that. Then we listen to that. So both negative and positive.
Yeah.
I think to me, because we all know what to do, but because again, I'm obsessed with these non-technical skill stuff. I think the mind should be kept open. I know, he thought of as a PE, okay, Now, I would have not thought the P because I keep on working on this stuff because we should have our mind divided into different segments. Okay, because in research, one segment is the diagnosis, but the most important thing is the process, the steps we are going to take it. Okay, but once we squeeze our mind in a particular direction, then the things get biased, so that we get biased. I think this was a clear situation of airway problem because he's got a laryngeal cancer and he's got a radiation. So radiation have fried his laryngeal artery, which is bleeding now. Okay, so it's for the foreign body obstruction or blood obstruction of the airway. I think, I would have, got the ENT surgeon and the anesthetic surgeon in the, when the patient arrived or before arrived, something like that. And probably then, because the more you fiddle with the airway, the more it will bleed, as you see in the scenario, because putting a laryngeal mask and intubation and, long set of Goodell airway, to me, it will, injure the larynx and will cause more of bleeding. So of course we have to go step by step, which is absolutely good.
But that's
I think
a good
yeah.
thought,
So
actually. Yes, because we have to see whether do we try to do anything or we're asking for help early. If you ask for help early, that's good. If they're around, if the anesthetists are there, he will be able to look after our ENT surgeon maybe. If they fail, then we can go to the ultimate thing.
Yeah, you're right. The other thing is the positioning, because there was quite a few position on the feet up, head down, whatever.
Yeah.
I know position is good, but I think in that scenario, the position probably won't work because this patient is bleeding from the blood vessel into the larynx.
Yeah.
So I don't know how the position would have affected or made it a bit better or what. I have no idea. But I think, of course, the positioning is one of the maneuver, the basic maneuver which we do. But overall, it was a very good attempt, excellently done, and I think we are getting there where these courses and spending money on ALS, ATLS, and struggling and traveling, that I hope will be thing of the past, and we will have in-house training as Reddy is doing. Yeah, Reddy, well done. Yeah, keep it up. That's what I would say.
Guys, anybody want to say anything, because we're going to prepare for the next session. So I think, what time is your break time? Is it at 11:30? Is it? No.
We can take break anytime.
I don't know. Like, if you guys want to have a quick break, we can start at 10:30 in 10 minutes. Other scenario.
Yeah, and then we'll stop the recording and then
restart. Is that okay?
Okay, that's good. Thank you.
That's fine. Yeah.
Should we stop the recording for now and
then
we can restart?
Restart that. Yeah.
Yeah. Oh, pause.
That's it.
Okay. Yeah. Okay, Rangini, are you happy to do the kind of timing again? The timelines?
Yeah, sure.
Yeah. I think it's kind of making sure that, we do the right things in order, something like that, to kind of go through again. Yeah. That's fine. So we're ready for the next scenario. Who's next? Who's my candidate? Sushil, you want to go for it? Yeah. Sushil is going to come here. Maybe I think people are going to be nice business. So, Sushil.
Yes, sir.
You're going to receive a how old is she? 30-year-old female.
30-year-old female.
Yeah, who's non-asthmatic.
Non-asthmatic.
And she's coming in with worsening breathing. She's really struggling to breathe. Actually, she's been trying her inhalers, not helping. She's really struggling. But she's been having cough for a couple of days, and they're not unwell. An ambulance wanted to bring her to reasons, basically, because they already given her a couple of meds, which is not helping her. That's the scenario.
All right.
So she's the 30-year-old called Amy Foster. She's non-asthmatic and she's struggling for a couple of days and getting worse, and she's really short of breath. And the ambulance are giving the nebulizers on the way.
So we've got a 30-year-old Amy, non-asthmatic, presented with a couple of days history of cough and likely worsening asthma. Do we have any numbers?
Numbers here. This time the ASHA person has given you the numbers for you, and there are a respiratory rate. If you ask for that is 26.
Rest 26, okay.
That's 26, and her saturations are 94% on the neb,
Fair enough.
and a heart rate of 120,
Mhm.
blood pressure 110 or 70.
Okay, and GCS,
This is 15.
ETA,
ETA 5 minutes.
and do we have an access?
They are struggling with access, but they will.
Excuse me, can I disturb for a minute? Yeah.
I'm sorry?
There is a fire going on in our accommodation. We were asked to evacuate. So
Okay.
just do the timing, please.
Oh, fine.
Yes, subscriber. I think we can use our own team here,
Yeah. Like we have the team here now.
Yeah.
So then you'll be able to use them. So we have a wonderful nurse with you.
Yeah.
And there is another F2 or F3. He's just doing locum today. He's F3 today.
Yeah.
So you can use him as well.
Okay, fair.
And obviously the registrar is working hard on an unplanned care side, and the consultant is in his office.
Okay.
He's doing some admin work. If you want, he can come in as well. Yeah, is that fair? Yeah, you can have planning around maybe in 5 minutes. The ETA is going to be 5 minutes.
So I think, as you know, I'm Sushil, I'm one of the doctors here. So we're expecting an SIs of a 30-year-old Amy Foster, non-asthmatic, who's likely to have an exacerbation. The rest rate of 26. I think hemodynamically stable, I forgot the number, saturation 94, ETA 5 minutes. Are we ALS trained?
Yes.
Yeah. So why don't we get hold of the resuscitation trolley, make sure the defibrillator, defib and everything is okay, make sure line and access and everything.
Yes, sir.
We will allocate your role according to the situation.
Sure.
Yeah. So, and would you also mind preparing the nebs, magnesium sulfate, some steroids, oxygen? And I think that's what we're going to require.
Okay, the patient is here. I'm the ambulance guy. Hey, all right?
Yeah. Hi.
This is today. This is Amy. Amy is not asthmatic, guys, and she's not feeling well, coughing for a couple of days, and she's using her inhalers, but I think she's not getting better. We've been giving, I think I've given 1 salbutamol and 1 Atrovent, and this is her second neb. And as I said, her observations are kind of okay. I saw her 94% on the neb. Is that okay, doc?
Yeah, absolutely. And do we know what any allergies?
She's not allergic to anything. No.
Okay.
No, allergic at all.
Thank you very
Is
much.
that okay? I have to go and have coffee again. There you go.
So would you mind hooking the patient to the monitor, please? Amy, hi. My name is Sushil. I'm one of the doctors here.
Hello. All right. How are you struggling?
So she's talking to me.
Yeah.
So I'm happy with the Airway. Just to make sure there's no any secretions, foreign body.
No secretions,
No
no.
any of the signs of airway obstruction.
No.
And oxygen saturation is 94%, right?
94 on the mask.
Yeah, 94. So then let's still put her on 50 liters of non-rebreather. Yeah.
She's having neb now, whether to continue the neb or do you want to?
No, let's get oxygen driven labs continue.
Okay, yeah.
Yeah.
So you kind of changing them to oxygen driven, yeah?
Yeah.
Yeah.
So oxygen driven labs going on. So I'm happy with the A at the moment.
Yeah.
Let's move to B. So I can see the misting of the mask.
Yeah.
What's the rest rate we said?
That's very 28.
28. And then what's the work of breathing?
Really sorry, I think it looks like it's very thin, as you can see.
Yeah.
And she, like you can see, her abdominal is working hard and chest is raising her off.
So
And she's really panicking as well. It looks
increased
like
work of breathing.
increased work of breathing.
Yeah, and then what do I hear when I auscultate?
Wheezing, expiratory release, expiratory release.
Expiratory
The bit of a reduced air entry basis is very tight. It's tight as well, but wheezing.
Yeah. So, so she's got wheezing and how about the patient?
Resonant.
So in terms of B, so we've got likely an area obstruction secondary to asthma. Sorry, lower area obstruction due to asthma. So let's do an prevent after this. So let's, in terms of C, would you mind getting hold of the axis?
Yeah, I've already got it.
So in terms of C, what's the peripheral pulse?
She's going at around 120 at the moment.
120, and the blood pressure is okay. Isn't it?
The blood pressure is okay.
Yeah.
But
So we will
about
put
the
the
110.
monitor.
So we put the monitor on, he's on, this put, yeah, if it's turn it on.
So she's on monitor. What's the central cap refills?
The central cap refill is about 2 seconds actually, yeah.
2 seconds.
Yeah.
So we're happy with it, and auscultation was nothing.
Operation is heart sounds all right.
So in terms of CM, I'm happy at the moment. I think partly tachycardic. Blood pressure, what was the number?
Blood pressure is 110 or 70.
Yeah. So let's give her 250 ml fluid bolus. So we can slightly tachycardic in both arms. And let's also prepare for 200 milligrams of hydrocortisone. Yeah. And are you happy to prepare for an ABG?
Yes, sure, I'll do that.
ABG. Okay.
Oh, you already got it, is it?
Okay.
That is very fast, man. You guys are very fast. You allocated the wrong one.
While we do the cannula, let's do a routine set of full blood count, using LFTs.
All done.
Yeah. Thank you. And will you let me know once the ABG is run?
Yes, sure.
So in terms of C, let's move to D. So Amy, how are you feeling? Are you feeling better?
I'm really struggling.
So still talking, making sense. Looks like has good central perfusion. What's the pupil?
It was equal and the oxygen actually.
Yeah, and we'll get to know the DM on the gas. So D wise, I'm quite happy. In terms of E, anything I can see, obviously, any rashes or
no rashes,
no rashes, nothing to be worried about in terms of E, no bleeding or anything.
So if you give the top one,
How much hydrocort do you want?
200.
Do we have done? VBC done yet?
VBG is done. He did the VBG first actually.
Okay.
Because he thought it's ABG, but he's an F3 guy from Scotland. He's a bit Scottish. So he thought it's an ABG, but it's actually VBG. And he's given me that. I don't know what that says, but you can read it out loud for everybody for them purposes as well.
So though it's a VVG, but we've got acidosis, pH 7.25, PCO2 7.2, and PO2 of only 4.2. So even if we disregard the PO2, so she is retaining, which is not a good thing. So I think we've got acute severe asthma because she is already retaining on the gas. So let's get some help because let's get the medical registrar here. Would you mind meeting the medical registrar?
Okay.
Yeah.
Okay, calling medical registrar.
Yes. So we've got a 30-year-old asthmatic patient in acute severe asthma. In terms of treatment, we've given her back-to-back nebs, Ibra, yes, nebulization with hydrocortisone. We've given 250 ml of fluid, isn't it? And let's reassess. So how we do? I'd like to go for an ABG because my turn is missed.
Yeah. I mean, if you're doing ABG now, going into the machine after you done that. Yeah. I'll go into the machine. Yeah. Wait for me to do it. Yeah. There you go. Yeah, I think it's cooking now.
Yeah. So let's reassess. So we're happy with the Airway. She is still talking to us.
She's but selection is really. I don't know to talk properly to you, but obviously she's still talking to you.
Yeah. So still talking. What's the work of breathing? Has Nebs helped?
No, I think she's still struggling. She's still breathing the same rate what she was doing, and
how about
V's all over?
Still no improvement at all.
No improvement at all.
Okay. And in terms of C, what's the number? Still tachycardic.
Yeah. Have you missed something? A SATs are now 92%.
That's 92%
on that neb driven by oxygen.
Yeah. Let's add a nasal prong so that we can add some supplementary. So she is being nebulized with 6 liters of oxygen driven nerves.
Yeah.
And let's put some additional oxygen on the nasal prong as well.
Okay. Yeah.
See if that helps. I think we should also be giving her some magnesium if the team agrees there. So let's give her 2 grams of magnesium as well.
Magnesium solid given.
Yeah.
2 grams.
Yes. And so in terms of C and in terms of D, she's still talking, nothing has changed in D.
She's talking, but like she's just closing her eyes and then referring to responding to open your eyes with the speech.
Yeah.
But
Responding only to voice.
Yeah.
So that's not a good sign. So I think the work of breathing and her conscious level is going back. So I think we need to get ahead of the situation. We need to plan for a possible.
ABG has cooked for you.
Okay.
That's ABG.
So AVG wise, pH 7.32. Again, PCO2 5.9, PO2 10.2, and then that's on how much? So that's on 6, and then
That's 2 liters.
no, that's on 6 on air driven, and then we've got further 4 liters on nasal pump. So PO2 I'm not happy. PCO2 5.9 just at the low end. Vital, potassium's okay, sodium's okay, glucose, lactate slight increase. So yes, it shows respiratory acidosis with type 1 respiratory failure as well. So I think we were gonna need. So where's the medical registrar?
He's on the way, man. He's talking.
Do you mind meeting the anesthetic team as well, because we might need airway support because we've been treating her for acute severe asthma, isn't it?
Is magnesium started or was it?
Yeah, we've given the magnesium.
How much you given her?
We've given her 2 grams of
2
magnesium.
grams. Is it given start or what? I don't know.
Over 20 minutes.
Okay, sorry.
So
That's
that's
still
going
going. It's still going through. Yeah. Fine. Yeah. Okay.
So let's review what we've done. So airway, we're still happy though. So so in terms of airway, though she's only responding to speech, but no signs of airway obstruction, right? So no stridor, still maintaining. Worker breathing, any improvement?
Worker breathing is she's a bit tiring now actually.
So I think team, the monitor shows a regular wide complex tachycardia. What's the blood pressure?
Blood pressure, if you check it now, it's we got the pulse. We got the pulse.
So we've got
the blood pressure is 90.
Blood pressure is 90
or 60. Yeah.
Should I put the pad on?
Yes, please. Let's put the pad on. Any chest auscultation?
It's the same thing what you have been hearing is all
Okay.
Oscar, it's all widespread wheezing actually, and you've been giving salbutamol, isn't it?
Yeah.
An ambulance had given 2 lots of salbutamol.
Okay. So we will just so she's on a wide complex tachycardia. We want to identify if she's got any adverse features or not. So the blood pressure is okay. She's not having any chest pain.
No pain, no chest pain.
No chest pain, no features of shock, but her conscious level is going down.
Yeah,
I think we should plan. Let's leave the anesthetics.
That's fine with that. Yeah. So anesthetist is here now.
Yeah.
This is just coming as an anesthetist there. So he's,
Hello.
Yeah.
What's
We've
going
got
on
this.
here?
Yeah, we've got this 30-year-old lady in acute severe asthma who
Yeah.
we were treating for, but suddenly went into wide complex tachy, and I think we might need to cardiovert her.
Okay.
Yeah, if you mind taking care of the sedation, then I think we will have to cardiovert her because her conscious level is only responding.
So
to
how
speech.
much more station do you need? What's her name?
Amy.
Amy.
That's the kind of repeat.
What's Amy doing? Is she responding in any way?
She's not responding to the speech actually.
So the repeat. So
what kind of sedation do you need? I mean, now she's
so
she's
we will
sedated
ask,
now, isn't she?
Yeah.
Do we have a pulse with that?
Yeah.
Yes.
But she got a pulse.
She does, but what's the blood pressure with that?
The blood pressure.
She now, like, if you do it again, it's 86 or 60.
Yeah.
She seems to have adverse features.
Yeah, that's why we want to cardiovert her.
Yeah.
Yeah.
Okay. I mean, her GCS is so low.
Yeah.
What more sedation do you need?
If you're happy with that, so
I can carry on.
yeah. So if you're happy to take, so let's. It's a wide complex tachycardia. Let's sync the rhythm, and let's give her the shock. Saurabh, would you mind making sure that we remove the oxygen and everything? Yeah. Let's sync the.
How much energy do you want?
So let's start with 120.
You got it tells you there.
You want to have here?
Yeah.
There's a list here. Tachycardia, 200 joules.
200. Okay.
So we are starting with 200 joules synchronized.
Synchronized.
Okay.
So
So
everybody ready? Yeah. So oxygen
now,
bottom.
charging now?
Clear, oxygen there. Charging. No, we don't need to charge. We just need to once it's stopped.
press. Delivering sock.
Yeah.
Yeah.
Oh. Yeah.
Delivering sock now all clear. Sock delivered.
Yeah. Thank
Okay.
you.
All right.
So we've got a gas in our
hold on.
hand,
So-
which shows the potassium.
She got a pulse, yeah, she got a pulse.
You got the pulse, yes?
Shall we do a blood pressure?
Yes, let's repeat the set of all.
What's the blood pressure?
So we've got a gas in our hand that shows a potassium of 2.2. All the other parameters are same. Still respiratory acidosis with PCO2 of 5.9. So let's start the patient on 40 millimoles of potassium chloride with a liter of normal saline over 6 hours.
Potassium on that?
2.2.
2.2.
Yeah.
Okay.
Other than that, let's review our patient again. So, she talking, Amy, can you hear me?
She just opens the eyes.
Yeah.
With the speech now.
She's still maintaining the airway, and we'll put her on 15 liters of non-rebreather now.
Yeah.
Yeah. In terms of B, what's the work of breathing?
Work of breathing. I think she's a bit tiring actually.
She's right. C-wise, still taking.
What stats do we have with the non-rebreathe mask?
SATs 92% on it.
Yeah. So still tachycardic. Let's give her another 250 mils of fluid bolus. In terms of D, only responding to speech, nothing has changed. Yeah. Anyway, happy. I think we might have to take care of the airway.
So you want me to intubate?
Yes, basically, because the patient's still on type 1 respiratory failure. PCO2 is at the
Type 2.
sorry, she's going to type 2 respiratory failure. And
She's got life-threatening asthma, doesn't she?
yeah. So I think she's moved from acute severe to life-threatening.
So have you got the drugs?
Yes, so we've got our drugs.
Yeah.
Guys, I think we're going to stop the scenario there. So we're going to hand over to the nice team there. Nice guys.
Yeah.
Right.
So hi, thank you for coming. So we've got 30-year-old Amy in life-threatening asthma. So she is non-asthmatic, has had a cough for last 2 days. Was brought in by the crew. In terms of the treatment in the department, she's had back-to-back labs with magnesium, and she's also had steroids, and she's had 40 millimoles of potassium for hypokalemia and 2 fluid boluses. I think we need to take care of her airway, and she needs to go further.
Yes, thank you. She's also had a VT.
Yes.
Yeah, with adverse features. Yeah.
Good guys, we'll stop you there. Good. Claps again. Okay. Shall we all sit again and have a chat again? Yeah. I think they wanted to give you this as well, but yes, I think it's gone off. Working, yeah.
Yeah, I keep moving the mouse.
Moving the mouse, and then it's not going to close.
It'll log out.
Yeah.
There you go.
Okay, you all chill out now. That's good. So I think we done it very quickly. I think this one, for 20 minutes or something like that, we didn't drag on. We are aware of the timings and the breaks and all that. How is it? How are you feeling? Feeling okay? Did you feel any stress at all at any point?
I wasn't expecting the patient to go to VT.
But it is a possibility. Is it like you keep on giving salbutamol, something like that? So is any complications can happen? Yeah, that's a kind of an addition actually. Yeah. And anything else?
I forgot to tell charge, but the project took care of the people.
Yeah. Just kind of making it safe to do the sync shock, isn't it? Yeah. Because sometimes there is a margin of something as well. Yeah.
But I tried to involve the medical team when we were going towards from acute severe to life threatening. So I tried to involve the anesthetic.
Good, isn't it? Yeah. So our main focus in this scenario is again the same thing again, and how do you kind of classify for life threatening to? Is there any other thing after that?
Near fatal.
Near fatal,
Yeah.
isn't it? Yeah, is it life threatening? And then are we moving into near fatal? And then what after? What are we going to do after that? You know, are we intubating and ventilating? What are the indications for intubation and ventilation in asthmatic patients? That's one side of things. And how do you use the resources and kind of team working again? Yeah. Okay. So it's like, because to kind of summarize, I think our Rangani is out of the area there, I think.
I'm back, but I didn't listen to the middle part.
Fine. I'll quickly summarize for everybody. Yeah, because I'll give the thing. Yeah. So we got the scenario, and you had 5 minutes to plan and anticipate, and then kind of structure your team. And after that, as soon as the patient arrived, she was really struggling, and he thought she's an acute severe asthma initially, and he started giving, he did a HIEM assessment, and after that started giving the nebulizers, steroids, and you giving oxygen-driven nebulizers, and done some bloods and a VBG, and then kind of kept reassessing that she's tiring, and he got the, ABG, and he realized it's life-threatening asthma, and you added on magnesium sulfate. At that point, the monitor started beeping, her tachycardia becomes worsened from 120 to 180. Why is this? And then on monitor, this is VT. So he confirmed that it is VT, actually. It's not artifact, it's VT. And he checked for pulse. That's a good thing. And then pulse was there, luckily. And she got adverse signs. You do a sync shock and revert it to sinus, and then back on track to treating a life-threatening but near fatal asthma, and then involved anesthetists to kind of take over, isn't it? That's the summary kind of gist of it, isn't it? Like, you're all with me, yeah? So, but to go through each point wise, like you're kind of really wonderfully, in the initial 5 minutes wise, like you worked really well. I mean, say like you had your team and you allocated roles, and you anticipated early, and you started saying, yeah, are you ALS trained? Why did you ask that? Is because
if we go to the worst case scenario, then I want to know,
as the patient gone into worst case scenario. Yeah. That's, I don't know why you said it. Are you ALS trained? That actually helped to you.
Yeah, because then I could comfortably let him take care of the defibrillator.
See, because I never asked, are you ALS trained? But that's a good thing to do. Like you asked for it, and you ask them to check the research trolley. That's a good point as well, isn't it? Yeah. And you kind of given the tasks to them, what to do and what medications I require. So you already asked for the nebs and steroids and magnesium. That's a good thing as well. Yeah. That's really wonderful. But kind of, this is all important to kind of, see, anticipate, and then plan accordingly. Then, it becomes easy to kind of treat, isn't it? Yeah, that's good. And after that, as the patient arrived, like you go on to A2E assessment, that's good, isn't it? That's sound. I didn't want to kind of concentrate on that anymore. But it was good to see the breathing point of it, kind of was respiratory rate and checking for resonant sounds. And why do you want to do that? Why did you do that?
The patient can have pneumothorax.
Pneumothorax, isn't it?
We want to.
Because if you think from the ambulance, he says life-threatening asthma, he says asthma exacerbation. If you've gone with that, if you don't properly examine, you might miss attention pneumothorax, maybe, like you might think the hypoxia is because of life-threatening asthma, rather than, with pneumothorax developing. So it's always important to kind of check completely, hospital in all areas and percus and all that. That's really good. And you made sure that this is still asthma and there's nothing else going on. And you changed the nebs to oxygen-driven nebs. That's a good thing. Yeah, and then you got to C already done. He's very good. He's already done your ABG already, but I didn't want to give the ABG initially, so he's got a VBG. At that point, like you said, guys, we're in acute severe asthma. Do you think is acute severe then, or is it life-threatening there?
No, I actually mispronounced this. What I wanted to say was it was life-threatening and going to near fatal, but I took a step beneath.
But does it really matter to exactly say it's acute severe or is it life-threatening asthma, guys? But management would be the same, but I think it might alert the team maybe better. Oh, it's life-threatening. Now we're in a bad situation. we're in a bad situation now here, isn't it? If you say acute severe, maybe I would have relaxed. Okay, yeah, fine. We're going to put anesthetic. That's fine, isn't it? But it's still life-threatening. Okay, we have to be very careful here now, isn't it? We are going in the wrong direction. So yeah, I think that wouldn't have changed the management there yet at that particular point of the time, but it would have helped the other members of the team maybe that we are doom is going to come back, isn't it? And you asked for medical help then? You asked for medical rights, but he didn't turn up yet. Yeah, and then what happened after that? Like you asked for magnesium and you realized the BP monitoring, wasn't it?
Yeah.
Would you expect that? Or did you expect it? Or
No, I think it happened during this.
because while I was planning the thing, I was making sure that I was able to control that, and you would have guessed it whether something happens, isn't it? But yeah, I think how common it can happen like this, because I never seen a life-threatening asthma going into something like that. But obviously, I wanted to throw a bit to kind of reassess every time why somebody goes into that, because it's still possible, isn't it? It's still possible because
what can be possible is the life-threatening asthma becomes sort of extremist, become respiratory arrest, then could turn into some sort of current.
and can the drugs what you're giving, can they make you have adverse reactions in terms of, if you say hypokalemia, if you keep on giving salbutamol, and if you become hypokalemic, they can give arrhythmias of any sort.
Yes.
You never know why they've gone into that now. Is it because this is kind of rethinking why this happened? Is there a reason why? Is it artifact or is it really a VT? Things like that, because that is the importance of reassessing the patient, going back and then make sure that what's the pulse rate now is 160. Why? Because how many times they become more tachycardic if you keep on giving this salbutamol? It can go more sinus tachy, maybe around 140s. But after that, I don't know. I never seen it, but anticipate it. Possible. It is possible. But at the same time, yeah, I think you're, if the was VT, have you dealt the VT right? Yeah. Correctly, the thing, yeah. I think you're talking about adverse signs. What are the adverse signs? What were those adverse signs?
So one is myocardial ischemia or chest pain, features of shock.
Yeah.
Which then syncopal symptoms, and then heart failure. Features of heart failure.
So yeah, I think if you see any of that, then with that numbers, then you would kind of electric cardiovert, isn't it? And you all know, and you didn't forget to say sync the button. Sync button is always important. If you miss that, what is the risk if you don't sync it?
So we might worsen. We might worsen.
They could lose. They could go to cardiac arrest because, like, you can give a shock at the recovery phase of the cycle, cardiac cycle, and then you can, pre-examine causing, cardiac arrest, isn't it? So it's always like, don't forget to sync the button, and then charging wise, like you have to charge it. Somebody said, you don't need to charge it, but you have to charge it.
No, I thought it was already charged, so that's why I said you
Oh,
don't
yeah.
have to charge it.
So it's already, because
It was me who was confused actually with the charge button.
and our monitors contains a slip behind it, how much energy you can give. I think each trust will change it. I think we're going to change it soon, I think. So according to us, it's 200 to start with, and then give that shock, and obviously it's a wonderful result for you, and you started acting on it, like you're replacing the potassium.
Yeah.
That was good. And after that, what did you do?
After that, we still needed to take care of the airway because of impending,
because like she's going downhill, isn't it? Like she's exhausted, and she's
and
tiring,
No GCS.
and PCO2 is going up. So then that is going to be a near fatal, isn't it?
Yeah.
So then the next thing is going to be what?
airway and ventilation.
Is there any other kind of medication you can think of giving drugs wise?
We could have thought of aminophylline.
Aminophylline, yeah. Anything else?
IV salbutamol.
IV salbutamol.
But then again, she's had so much salbutamol. How much
If
more?
you give
do you
IV again,
Yeah.
we've already seen that we're sign now, but obviously is it kind of weighing the benefits and the risks of it? It's going to be tough as well, isn't it? Any other drugs you think of? About you, panel, about you, the virtual panel. Any more drugs you can give?
Ketamine.
Ketamine? the ketamine is a bronchodilator. Being a small dose.
I've never used
You
it.
never used
That's
it. I never used it.
perfect. I've never
Probably
used
think
it.
there.
No, it's,
Okay.
we are talking about rapid sequences.
Yes, because because we're kind of talking about intubation and ventilation, but before that, is there anything we can do by the time they're going to get ready to do the rapid sequence induction or delayed sequence induction? What they say in asthmas.
I think RSI has got a definite set of steps, are they? And it. I don't know whether it's mentioned ketamine as well. I have no idea.
Because for the induction thing, they could choose ketamine is the better one because it's kind of helps bronchodilate, isn't it? So they would use it because it's all kind of choices of the anesthetist who's doing it. But they would prefer to go for ketamine rather than anything else, I think. Because if they go for other drugs, propofol and stuff, they can cause more hypotension, something like that in the situation. But it all kind of depends on the kind of experience and the familiarity with the drugs of the ITU person. But as the ED team, we kind of help them to kind of facilitate those if they're on the way. Yeah, because at what point you want to involve the ITU guys?
When we think that medical management is not helping and the patient moving on to near fatal things.
Do you wait until near fatal, or is it life-threatening?
If you think they're starting to
tire, yeah,
you involve them. If you do a gas at any point and the CO2 is normal.
So as you're there now, so what are the kind of signs of life-threatening asthma? We can go around if we want to.
Yeah. So silent chest.
Silent chest, yeah.
So it could be PCO2 within normal range.
Within normal range is bad. Normally, if they're breathing very fast, it should be low.
Yes.
If it's acute severe asthma, it has to be low because they're hyperventilating, blowing off CO2 because they're tachypneic. So it has to be low. But if it's normal, means they are tiring a bit, guys. Yeah, this is a bad sign. But normal is life-threatening, is it? Yeah, that's a good one to kind of remember. That's an important point. One.
So which one? So
the tiring, exhaustion,
silent chest,
CO2,
normal or high CO2, exhaustion. Tiring. So
tiring, exhaustion. Anything else?
Reduced GCS.
Reduced GCS. What do you?
Is it oxygen low than 92%?
92%, I think. Yeah, it's like threatening asthma. Oxygen low at 92%. Hypotension, arrhythmias, anything like that. Anything is life-threatening. If they're tiring, if they can't complete sentences, that's acute severe asthma, isn't it? But if they have any of these features, you have to think of life-threatening. Then you should involve the specialist now, and then by the time they come, they'll plan around. You can start these management plans, like with magnesium, thinking of salbutamol and back-to-back nebs and steroids on board and things like that, and making sure there's no other complications like pneumothoraces, tension pneumothorax, things like that, and then wait for them to come down quickly, and then maybe going for, if they're going to near fatal, means what? What are those signs of near fatal?
CO2 retention on gas.
If it's going up and if they're becoming more unwell, then it's near fatal, then they have to be there, and you have to plan for intubation and ventilation. And
there's a question.
Yeah.
Chest X-ray or ultrasound the lung is a part of primary assessment or the secondary sort of survey.
Guys, any answer for that?
No, I mean, I'd get a portable chest X-ray in that case.
In that case, if
I
they
would have
have
had a portable chest X-ray, with the initial gas.
so could you do X-rays in all the acute severe asthma patients? Would you do or would you not?
So did we do the chest X-ray in this situation?
In this situation, like if he is life-threatening, I would do a chest X-ray. Because make sure there's no things.
Yeah, because this is a case of critical desaturation of oxygen. Now, of course, it's an acute severe attack for asthma, but the complication of asthma, they are the killer really. One is acute desaturation of oxygen, And the second complication is a massive set of pneumothorax. I think the nebulizer stuff like that will tackle the desaturation, but the pneumothorax is a bit of a problem because most of the people with asthma die with this complication. And the chest X-ray, I think, is important, or some sort of ultrasound scan to rule out pneumothorax. And the other thing is for purpose of intubation as well.
So it's like, if you're expert in it, if you're kind of level 1, you can easily make sure there's no pneumothorax quickly. Make sure, on arrival of the X-ray, guys in the portable X-ray, it's easy to do kind of quick chest ultrasound, making sure there's no pneumothorax. I'm not an expert of doing other things, but we can easily see, we can easily learn that. Yeah. And
because we have a recent cardiac arrest. I don't know, people will know, some of us who are here will know about this gentleman. I think a 60-year-old gentleman. He was staying with his friend or living there, I don't know. So the friend heard a thud and he went in, he was collapsing unresponsive. So he starts like CPR doing. And then the paramedics were called in, they put the LMA. And when we saw him in resus, so, and we exposed him, so his scrotum was quite swollen up. And we thought it might be hydrocele, but then we looked a bit closely, the neck was swelling up as well. So then we, put our hand on the neck and the scrotum and the chest. So it was all subcutaneous emphysema.
Yeah.
So then, he's got, we've done chest X, he's got a couple of rib fracture as well. You see what I mean? So, I mean, if they start intubating massive pneumothorax, so then, it's a problem.
Definitely, because
you have to do the thoracostomy.
Yeah. I think, but definitely in this situation, it's life-threatening asthma becoming hypoxic, then you would want to make sure, because if they are doing intubation and mechanical ventilation, the small pneumothoraces can become tension and then cause problems in the cardiac arrest, something like that. So I think making sure is an important thing. There's no pneumothorax in life-threatening situation like this. Yes, we can do ultrasound, but I think for different process, I think do an X-ray chest. Yeah. And obviously, yeah, I think we are okay. Is there any area for NIV here? Non-invasive ventilation before intubation? That's food for thought.
The patient was already low on GCS.
Yeah, exactly.
Yeah, because the indications for NIV, they have to be alert, cooperative, and if you think they're going to be improving soon quickly, they wouldn't need to, because anesthetists don't want to intubate asthmatics. It's going to be tough. So I think just wait at the right moment. If you intubate them, then it's going to be difficult after that to come back in extubation there. So I think better avoid it if you can, but monitor in a critical care environment. And then there is an element of whether to try an IV or not, but there's no proper evidence for it. But I just wanted to say it. Good. Happy with all that? Yeah. Quickly go through the learning points. One learning point from each of you. What did you learn from this?
I was able to learn in every situation of a patient, we have to do ABCD and repeat it again and again as Dr.
But reassess, keep reassessing that there might be a complication going on. After you give an intervention, whether it's worked or not, whether something else happened or not, go back and reassess again. That's a good point. Yeah. What about you?
Be alert to identify the life-threatening reflex. So, as in at the back of the head.
At the back of the head, yeah. Guys, are we there?
Keep beating by the back of the head, saying, okay, any life-threatening.
Yeah.
Because then you quickly flip and switch on the pathway.
Yeah. Good. Yeah. What about you, Marius?
What I do when I have an asthmatic patient in resus, for example, what I do is print out the BTS guidance.
Good one.
Because I can never remember
things,
all the things.
Because how many will remember?
Classification. So I just print it off. And then I know, oh, my patient actually, I thought they were severe, but they're life-threatening because of this. So I always print it off.
That's a good one, actually, guys. I think because of how many times we remember, we don't remember. So I think it's better to have a guideline with you. And then, okay, guys, I think I've done this, I've done that. Oh, I missed that, because everybody knows that easy to miss.
Do we have it in our resource?
I think we're having MyEB guidelines.
No,
I'm assuming that, but in BTS, what you're saying is,
yes,
you go to the website, BTS guidance.
Or
I think
it's in minding. Yeah, it's in minding.
So it's like, why don't we have a team today, have a look at the MyED and then see is up to date or not. And if it's not up to date, it's old 15, 20 years ago, why can't you just update it and then say, I've done a quality improvement program, guys, yeah? It's easy to kind of in a CV, but you have to update it, isn't it? Yeah, that's a good one. Print out. What about Sushil?
Yeah, I think apart from the fact that we've done, yeah, we should have thought about considering NIV. We didn't even think it was straight.
But it's a possibility, like you can think, if she's alert and cooperative and all that, and if she really kind of like struggling, then I think you can try that. But yes, yeah, I think look for other alternatives, like arrhythmias can happen with salbutamol and stuff like that. So always keep an eye on it. What about you? Yeah. Saurabh. Why do I say Sundar, man? I always say that.
Everybody says Sundar.
It's always confusing, man. Sundar and Saurabh. Both of them are sisters?
Yeah.
That's the issue, maybe. Yeah. There you go.
It's confusing at all, but I get it.
So have they covered everything, isn't it?
Yeah, almost. The assessment, yeah, I think it was good. The way he went in again and again, because it was quite dynamic a case, isn't it?
Yeah,
because, we wouldn't really expect VT on that.
So good, man. I think
yeah.
the learning points are here, kind of life-threatening to near fatal. Always important to make sure the PCO2, if it's raising or lowering like that. Always involved with the specialist ITU guys. Yeah, good. I think we have got another 40 minutes for the last scenario. Are you all with me? You're happy to stay for that scenario?
You really want to super saturate us?
No, in Aftab, I was given for 3 hours. I've been launching for audience like this, and so it's like, because if I'm doing a sim session, kind of 2-3 people are coming, and now I have
no, because you approach us first time. You see,
this is
you didn't approach us before.
I can do more and more if you guys really like it.
Of course, we would like it. Of course, because the more we do, the better we get. I think for me, learning points is that being systematic, very important. I mean, if a person can talk to me in resource, I will immediately put 15-liter oxygen on the face, and then I will start asking nurse, put a pulse oximeter, do a cardiac monitor, put blood pressure cuff. Okay, can you put IV line? Like A, B, C, D. Can you expose it? Have you done the blood sugar level? So involve your team with you. That's very important. And because I've seen people stood up at the bedside with the arm folded on front of the tummy or the chest. That's no good at all. So keep your team engaged. Keep on thinking. Keep on doing stuff. Preemption is very important. And please don't riddle your mind with the biases like, oh no, might be that thing. Keep your mind open. Keep a focus on the process, like a symptomatic treatment. So, of course, we should have some sort of idea in our head what we are dealing with. But I think the success depends on the symptomatic treatment, keeping mind open and being systematic, making sure that no step is missed. And keep the team engaged and listen to the team. Very important.
Good. Yeah, really good.
What is the case for peak expiratory flow rate in this kind of, deteriorating patient? Can we still use that? Because I was not there for the initial part. I'm sorry for asking that.
No. I didn't get you, Rangini. What exactly is it?
Peak expiratory flow rate measurement.
Yes. Definitely.
Are we using this kind of situations?
Because I think it's a good start, but obviously, like the patient is really struggling, and asking her to do a peak flow, then
peak explometer should be used. I don't know what the BTS guidelines say. Should be used in uncontrolled asthma, not in resus situation, because in resus situation is almost nearly acute severe attack of asthma, which we already know. So diagnosis are, resources most likely is there. So if we start using peak flow meter, whatever, so probably, one is the person won't be able to do it because the person won't be able to talk in sentences, won't be able to hold the breath to blow in a tube, not at all. You can do it, but I think I've never seen people doing in resource situation.
So it's like Rangini, if I want to answer in a different style, because
any of the features of life-threatening asthma, if it's there, I don't need to have the peak flow. It's like if they're really struggling, if the respiratory rate is high.
But the guideline says like less than 50%, less than 33%.
I know. This is one of the indication, isn't it? If that's peak flow low, or if the respiratory rate is more than this, or if SATs are less than 92, it's already kind of life-threatening asthma. Like you don't need to have all of them, isn't it? Any one of that will consider into that acute severe asthma, isn't it?
So does that mean that we are supposed to do that 33? I mean, so it
No,
means
the guidelines is a light which you shine to find your way. If my way is going to a ditch, I will avoid the ditch because the light is telling me there's a ditch in front of us. Guidelines are the light which you shine to find the way. It's not the rule, you know. So guidelines, you can use guideline. I think mostly guidelines are used to impress other people, or when we make mistake to think of the guideline, that sort of stuff. But once you're managing, go with the flow, go with the situation. And in research situation, honestly, I've never seen anybody doing peak flow.
So yeah, anybody wants to say anything from the virtual team? Because I think there's no more time for the next one, so we kind of conclude it. If you're all happy with it. Yeah.
I just want to add regarding the management and the classification of asthma, right? So I tried to check in my ED like recently in the last 1 month, around 2 times. There's no guidelines or anything as such. So like there's something error or something comes in.
Okay, so I think there is an opportunity for anybody who wants to kind of take this project, because it's an important kind of and more common problem as well. So if anybody wants to kind of take that as a, as a task or something, if you can improve the guideline, it would be wonderful, actually.
Actually, like it was there like a couple of months back. So for some reason, when you click on it, it doesn't take us to the server or something like that. So there's a network issue with that.
The 404 server.
404 servers. I think, yeah, because, but Firaz is the lead for MyED. I think we can have a chat with him and then make sure that he will sort that out. Yeah.
All right.
That's good, that's good. So yeah, guys, please give me feedback, and I think we can have a good range of scenarios. But obviously, if you think,
I think the next session you can do on a pediatric essay.
No, but the next session is already planned. Is a PEDS one.
What's the next session?
Is a PEDS one, but I wanted to do it, but if I say it's not going to be good, isn't it? So, because I want to do a PEDS session today as well, but
no, that will be rushed, is it? That session will be rushed now, and nobody will understand. I mean, you can, if you speak to Dr. Boone, you can have a whole 3 hours for the pediatric as well.
Yes. I think next time I'll do on PEDS. I think it'll be good, isn't it?
And PEDS and one scenario at least for the neonate, because the neonate is very important.
Yeah. But definitely Aftab, yeah, because please let me know, like if you want to have any particular topic, then we can kind of write a scenario and we can practice it.
No, I mean, what we could do is we will limit ourselves to 2 scenarios.
Yeah.
One cardiac arrest in the pediatrics, and one in the neonate.
Yes.
And we have a good discussion, good set of preparation. We all come with preparedness and prior reading and reading ourselves.
Yeah.
We all chipped in. We all be absolutely like a really proper set of bouquet set of scenario. I think it's very good ready, because I hate to go to ALS, ATLS, stuff like that, wasting my money and coming out learn nothing, quite frankly. You know what? Because that's a difference between American system and the British system.
Yeah.
In British system, there's a hegemony. For instance, there's some professor, some teacher, only they have to do, nobody else. But in American system, that's what we are following here now. So everybody should be able to do it. Everybody should be able to practice, and everybody should be feeling equally confident, equally sort of intervention. I think in-house training is the first step to that.
Yeah. Aftab, yes, I think boys, are we closing the scenario now? Yeah.
Yeah, that's fine. Thank you very much.
So thank you for attending, guys, and it's really wonderful to see all you guys to kind of make this wonderful.
Have a nice evening. Bye-bye.
And successful. But thank you.
Bye-bye.
Thank you for Dr. Reddy. I think this is excellent. We should continue doing this.
Yeah, yeah.
And basically, not knowing the topic is also putting us at more of understanding how to deal with the emergency scenario rather than absolutely prepared it, like thoroughly read it and everything.
Yes,
but it's more to do with like, okay, we've got only 5 minutes. Ambulance is here. Let's do something. Don't know what's going in mind. Go through ABC. This is what the preparation is. Not like reading all the books and coming back.
Yes,
I think it should have to be spontaneous.
Yes, yes.
Thank you very much, Dr.
Thank you for that. Thank you, Suraj. Thank you. Thank you. Close this, Anway. There you go. End the session. And